My name is Gustavo Nigenda. I'm professor at the National School of Nursing and Obstetric from the National University of Mexico. And in that school, I do teaching and I do research, particularly in areas of health systems, health policies, and specifically on human resources for health and nursing, and as well in some issues regarding reproductive health in Mexican and Latin American populations. In Mexico, we have a little more than 10 million people that are considered indigenous, and they represent also around 60 ethnic groups. Most of these groups live in 3 southern states in Mexico, which are Oaxaca, Guerrero, and Chiapas. Indigenous populations for many centuries have been living in poverty conditions, and the investment that the public institutions make, particularly in health, is too low for them to have enough services to be provided. And we have been studying these populations in Chiapas and Oaxaca regarding the provision of sexual and maternal services in the states for indigenous populations. Indigenous groups are very special kind of people because they have their own cultural traits. They have a worldview quite different from us. They see reproduction and they see life in a very different way. So most of the history of the Ministry of Health or Secretariat of Health, the care is provided a different kind of way of thinking, mainly asking people to come to the health center, asking people to adapt to the standards of medical care. But I think it is important to have a 180 degrees turn, because we need to understand how these people behave, how these people think regarding particularly reproductive issues, which may allow us to be closer to them, to really be able to provide them what they need. Not only from where we see that need, but from the way they see the same needs, which may be experienced in a very different way. So understanding how indigenous populations can receive care, not only in reproductive health issues, but in general in other type of issues, it is very important. Well, in the last 10 years, Mexico has reduced the rate of maternal mortality from 55 to 35 deaths per 10,000. But in Oaxaca and Chiapas, this is maintained above 40 deaths per 10,000 births. So we decided to go and do this study to identify which were some kind of models of provision of this type of services for indigenous populations. And we found that in Oaxaca, there was like the standard type of healthcare provision, meaning that they are mainly practiced by doctors and they are not using the protocol of respected or humanized birth. While in Chiapas, there is an NGO that is having a kind of agreement with the government to put in practice a type of model so-called humanized or respected. And also the provision is based on obstetric nurses instead of doctors. So these are the main difference of the two models. It is based on the right of women to decide some issues regarding the care. Two of them which are quite relevant are, first, the position in which the woman would like to give birth, and second, the possibility of having relatives or friends or even a traditional midwife that is accompanying the woman in the space where she is giving birth. So these are two main basic things but are quite relevant because they are not included in the standard model of care. Regarding the basic resources, meaning personnel and medicines and equipment and the spaces where the care was provided. There were not many differences, but they were very similar. But in terms of the results of having the possibility of providing a care which was satisfactory for women, we found big difference because women are quite satisfied because they are given the possibility of having a position which they feel more comfortable, or even having the spouse or the mother or the traditional midwife accompanying them. So the level of satisfaction was very different in terms of this. But also we found that in the NGO, in between 2016 and 2020, they care for more than 500 deliveries, and none of these women had died or was reported as maternal mortality. And also those who were found that to be difficult to care, they were transferred to other level of care, which was a general hospital. This means that the group there, the nurses, they're not only capable of providing good care, but also they know exactly which are their limits in terms of what they can provide and what cannot provide. The place, which is called the Birthing Center in Chiapas, is within the premise of a general hospital. Interestingly, they started with this model, but doctors in the hospital were not very happy with it. And after 2 years, they started to understand much better which were the advantages. And today, they will be taking a course to provide care based on the humanized model. So they know also they have been identifying their own limits, but we know that they have a lot of capacities, to provide care. So the combination of both is emerging like something that it was not planned, but it is now a reality. And opposite in Oaxaca, we don't have that type of situation because care is still dominated by the traditional model or the standard model, and they don't have a clear idea what humanized or respected type of care it is. So take all this information and take all the experience to other areas to show how it can work beautifully when you combine both.